طيب السلام عليكم ورحمة الله وبركاته جميعا وجمعة مباركة عليكم. And firstly, thank you to the faculty who made themselves available on their weekend and to our audience. I was just speaking to our esteemed faculty that as an interventional cardiologist, I feel just a heavy or dead weight in this group. But I think for me, it was an opportunity to learn a little bit more about the latest evidence in heart failure. Because it is a matter of fact. We're all seeing more patients with heart failure, not enough heart failure experts around the world, let alone the kingdom. And so it's incumbent on all of us as clinicians to manage these patients, and we need to stay at pace with what's happening. So let me quickly introduce you with our faculty. طبعا Dr. Faiz Al-Shair, he is a professor of cardiology at King Saud University, King Khalid University in Riyadh. Dr. Musaid Al-Hussein is an assistant professor of medicine, heart failure and transplant cardiologist at King Saud bin Abdulaziz University in Riyadh, as well as King Faisal Specialist Hospital and Research Center. Dr. Kamal Ghalayini, he's a professor of cardiology, the vice dean for clinical affairs, founder of the heart failure program at King Abdulaziz University Hospital, the director of their non-invasive cardiology lab, and currently the president of the Saudi Heart Failure Working Group. So without delay, we're going to move on to our first presenter, Dr. Faiz Al-Shair, who's going to discuss Emperor Reduce Trial, the clinical implications and outcomes contextualized. So over to you, Dr. Faiz, please.
Good afternoon. I would like to thank the Saudi Heart Association for inviting me to that very important event. And also I would like to thank the Boehringer for arranging and organizing this webinars with an excellent speakers and excellent attendee. And my task today is to just give an idea about the Emperor Reduce trial, clinical implications and outcome. So we know that heart failure is by definition is the heart cannot pump or cannot meet the metabolic requirement of the patients, and this will lead to some sort of compensatory mechanism, increased venous pressure, sympathetic over nervous system activation and natriuresis, and then kidney injury with the decline in kidney function and the hypoperfusion and subsequent decline in EGFR, together with activation of the vasoconstrictor substance and also in sodium and water retention. So worsening of kidney, of heart failure leading to worsening of kidney function, and this is a vicious circle. There is a lot of mechanisms leading to that heart failure, either immune mediated, increased cytokines and endothelial dysfunction, or hemodynamically mediated, like increased venous pressure, reduction in the cardiac output and decreased perfusion, or humoral factors either with or without or against vasoconstrictor or vasodilator, BNP and natriuresis, and humorally mediated damage like activation of RAS system, sodium and water retention and vasoconstriction. So it is a circle of cardiorenal affection. We know that more than 60 million patients worldwide had heart failure, and in 2016, about 80,000 deaths in US. Approximately 50% of our patients die within 5 years, and 30% die within the first year. So heart failure is one of the leading cause of hospitalization and rehospitalization in age more than 65 years, either HFpEF or HFrEF, and readmission rate after hospitalization was about 30% in the first 3 months, and about approximately 30% die within 1 year. So we have a lot of programs for regarding SGLT2 and heart failures, and we have a lot of medications started by in 1985 by ACE inhibitor and ARB, mineralocorticoid, beta blocker, ARNI, digoxin, hydralazine, azoxybutyl nitrate. There is a lot of evidence for the medication affecting heart. We know that still there is unmet need for patients with heart failure, and we have still 50% die within 5 years. This is in HFrEF patients, but in HFpEF patient, we know that we don't have a great evidence, and that's why the therapy demonstrated the benefit of is not very well observed. In spite of that, some studies showed the survival and the reduction in survival benefit and the reduction in heart failure hospitalization. The outcome from the cardiorenal benefit shown from SGLT2 during the various studies, EMBARC trial and Canvas program or DECLARE or Veritas cardiovascular and erythropoietin, and there is a reduction in the heart failure hospitalization by about 35% and cardiovascular death by about 38% and kidney outcome by 39%. Those in patients with diabetes. And it was there's a lot of speculation the mechanism about the value of SGLT2 in patients with heart failure, ranging from reduction in interstitial edema as well as intravascular edema, and also reduction in the preload and afterload, reduction in the wall stress, and improved kidney function and cardiorenal physiology, together with inhibition of the sodium hydrogen exchange and improve cardiac bioenergetic with natriuresis. So the story started from patients with diabetes type 2 to diabetic and non-diabetic, and started in heart failure prevention, the primary prevention to heart failure treatment, and all the stages from normal left ventricular function to the end stage heart failure. So there is a lot of trials and a lot of studies, programs about this. Clinical programs, we have two trials, the DABA-HF and EMBER-reduced trial. The DABA-HF is using induced patients who have HFrEF but at lower risk than the EMBER-reduced. EMBER-reduced patients are higher risk end. So the EMBER-reduced trial, this was published in 2020 in European Society of Cardiology in August, and the study was phase 3 randomized double-blind placebo-controlled trial, and the aim was to investigate safety and the efficacy of empagliflozin versus placebo on top of guideline-directed medical therapy in patients with reduced ejection fraction. So patients with ejection fraction less than 40, less than or equal 40, given empagliflozin 10 milligram plus the standard of care, and placebo plus standard of care, and followed up for 16 months. The primary endpoint was composite primary endpoint of time to first event of adjudicated cardiovascular death or adjudicated heart failure hospitalization, and secondary endpoint was first and recurrent adjudicated heart failure hospitalization event or slope of AGFR. The study started by 7,200 patients and ended up with 3,700 patients. A lot of people excluded because of consent or for other reasons, and then they are divided in two groups, 1,800 in each group, and they are followed up till the end and analyzed by intention to treat analysis. What is the inclusion criteria? Inclusion criteria, as usual, age more than 18 and near class 2 to 4. However, the most of the patient in class 2 and 3, 4 is rare, and ejection fraction 40 or less. We know that they divide the ejection, they have strict criteria, and they have, if the ejection fraction from 36 to 40, and if a patient, the BNB should be, NT-proBNP should be more than 2,500, and if it is from 31 to 35, more than or equals 1,000, and less than 30, more than 600, and if the patient is hospitalized within 12 months, they should have BNP more than 600 if the patient is in atrial fibrillations. So what is the exclusion criteria? Coronary artery bypass surgery or MIs or cardiovascular surgery or stroke recent within 3 months should not be included, and heart transplant recipient or on list for heart transplant, acute cardiac decompensation, or systolic blood pressure more than 180 millimeter mercury at visit 2, and systolic hypertension less than 100, or EGFR less than 20. So we look at here, the groups are equal. Those who are given empagliflozin and placebo, the age is around 67, the same, and women represent about 25% in both groups, and white, it is mainly done in white, 71%. Black and Asian are also presented. They are North American, mainly Latin American and Europe. Together with the class 2 is 75%, and class 3 is about 24%, while class 4 is 0.5%. It's not very well presented, and the groups are equal. So the body mass index, they are about 28 in mean and 27 here. And heart rate 71, so they are in a good management for regarding the heart rate. Systolic blood pressure is about 120. And if we look at the ejection fraction, less than 30 represent about 71 or 72% of those patients. NT-proBNP is 1,800, high BNP compared to DAPA-HF trial. Ischemic 52 and non-ischemic is about 47. Hospitalization for heart failure more 31%. Atrial fibrillation patients are presented also about 35%. Diabetic are about 50% and hypertension 72%. EGFR mean is 6.61 and the less than 60 is about 48%. Those patients are on the guideline directed medical therapy, and ARNI here was presented by around 18%. However, in another trial like DAPA-HF, the ARNI was about 10%. So here they are more updated with the guideline. Implantable cardioverter ICD about 31%, CRT is around 11%. So what is the outcome? The outcome shown here that the primary composite outcome of mortality and the heart failure hospitalization, relative risk reduction is about 25%, absolute risk reduction is 5.2%, and number needed to treat is 19%. That is very good result. And so we go for subgroup analysis, diabetic versus non-diabetic. It is shown the same effect, and age more than 65 and less than 65 the same, male and female also, and more old ethnicity, and the white usually inspired that more they are more presented is just touching the unity line, and the baseline those who are more than 30, they are crosses the unity line. The EGFR less than 60 and more than 60 is still has shown the effect. This heart failure hospitalized patients also show the same effect, and causes of heart failure either ischemic or non-ischemic. We have the same not crossing the unity line, and in class 2 and class 3 also the effect is there. The issue here, ejection fraction and NT-proBNP also shown to be significantly affected. Given MRAs or no MRAs, the same, the benefit was there, and R-need also the same, the benefit is there. So in most of the group studies, they are all significant. So key secondary endpoint for the heart failure hospitalization, first and recurrent, it was relative risk reduction about reduced by about 30% in favor of empagliflozin. And this here, the emergency visit and urgent care for heart failure, it is the effect is shown early as 12 days and persistent up after 34 days and continue till throughout the year. If we come to the analysis, according to the baseline nebulizer inhibitor, it was found that, as I mentioned, all given nebulizer or no nebulizer and all patients is in favor of empagliflozin, and the first or recurrent heart failure hospitalization also in favor of empagliflozin. For the secondary endpoint of EGFR, we know that it decreased the decline of EGFR with time. However, there is an initial drop due to efferent vasodilation, and this will persist up to 3 months. Then the creatine clearance is improving, and empagliflozin shown that after stopping, if you stop the empagliflozin after stopping, there is still a rise in the EGFR after 1 month. Here, the initial drop is seen in the EMPARIC trial, also the same in the first 3 months, and then continue to improve, not decrease the decline of GFR. So the empagliflozin, the decline is about 0.6 ml per minute per year, but in placebo minus 2.2% per year. So there is a difference of about 1.7%. So the decrease, decline, and worsening of creatinine clearance. So the efficacy of the primary endpoint, we saw that here the sustained profound reduction in EGFR, relative risk reduction about 50% and absolute risk reduction about 1.5. This is a composite of end-stage renal disease and profound reduction in the EGFR. So we have a persistent cardiorenal effect. If you compare this and those who had the renal impairment and with taking nebulizer or no, the difference in EGFR slope is still better even with giving a nebulizer inhibitor. So the nebulizer plus empagliflozin, there is a reduction in the worsening of kidney function. Quality of life questionnaire, KCCQ, clinical summary score, it was the absolute difference rise in 1.7 compared to placebo. If you come here, the result baseline of nebulizer for the symptom. So improvement of the symptom, if you give a nebulizer or no nebulizer, all in favor of empagliflozin. And if for worsening, there is no worsening. So the worsening of symptoms is still not in favor of the empagliflozin, no worsening of symptoms. So here we have the primary endpoint is confirmed, the adjudicated cardiovascular death or heart failure hospitalization, adjudicated first and recurrent heart failure hospitalization, and key secondary endpoint EGFR slope is confirmatory. This is the p-value of this point, less than 0.001 in all the endpoints. So an overview, heart failure hospitalization and cardiovascular death decreased by about 25% relative risk reduction. The total heart failure hospitalization is reduced by about 30 relative risk reduction percent, and EGFR is improved, decreased decline of EGFR by 0.17, and the composite kidney outcome reduced by about 50%, and Kansas City score, cardiomyopathy score, is increased by about 1.7%. So what is the safety outcome? Safety outcome in those patients, either HFrEF, diabetic or non-diabetic, or GFR more than 20. The volume depletion is occur as in placebo, about 10% here. Hypotension not significant. Also systemic hypotension occur only in 5.7% as placebo, and confirmed the severe hypoglycemic event is not significant, 1.4 in patient with or without diabetes. So urinary tract infection occur in 1%, and complicated occur in 0.3%. So we don't have a greater significant difference between both of them. If you look at the glycosylated hemoglobin, there is a reduction 0.2 with no significant compared to placebo. Hematocrit value is increased, improve erythropoietin secretions. It can decrease anemia. NT-proBNP is reduced, and body weight is a little bit reduced, but not much significant. And systolic blood pressure is only -2. Here, the empagliflozin reduce the hemoglobin A1C in diabetic, but however, in non-diabetic, there is no reduction in hemoglobin A1C, so it is safe in non-diabetic patients. Safety profile in patients with diabetes and without diabetes. For looking at the glycemic disorder, no cases with diabetic ketoacidosis were recorded, and no cases with severe hypoglycemic episodes. Empagliflozin had a favorable profile, even in patients with compromised kidney function. This is the same shown here for regarding the adverse event. So volume depletion with empagliflozin was not significant, even not influenced by the high risk group, diabetic, kidney function, age, ejection fraction, systolic blood pressure. So volume depletion was not manifested, and if you have it, you can reduce the dose of diuresis. The systemic hypotension also is not significantly occurred in high-risk patients like diabetic, kidney function, age, ejection fraction, systolic blood pressure, and liberalizing. So what is the guideline saying here? That now a new class 1 recommendation in therapy in HFrEF, SGLT2 inhibitor, dapagliflozin or empagliflozin. The 4 key drug therapy should be initiated as quickly as and safely as possible, and importance of the tailored management. Here, the dapagliflozin is jumped to the green green color here, and it is just taking class 1A and the level of evidence A, and those patients with the other with ACE inhibitor, ARNI, beta blocker, MRAs, and loop diuretics here, and then you go across the rest of the management of according to the algorithm of heart failure. So here, the class 1 recommendation, dapagliflozin and empagliflozin are recommended in patients with HFrEF to reduce the risk of hospitalization and death. Then phenotypic approach, yes, we give the 4 pillars. Our founder, ACE inhibitor, beta blocker, MRAs, SGLT2, and the diuretic and volume overload, and then you go the rest for the management of heart failure and complete the algorithm for management. So in summary, we for foundational therapy, RAS, beta blocker, MRAs, and SGLT2 should be given in your patient in small doses. We know that the dosing system consecutive management, and SGLT2 inhibitor, ARNI, and evidence-based beta blocker and aldosterone are the first line for treatment of all patient population with HFrEF. No need for titration or additional monitoring, and expert guidance already included SGLT2 inhibitor for heart failure, and the upcoming guidelines are currently being updated for that. So let us to do critical appraisal for that trial. So mainly I discussed the trial, so I will do the critical appraisal. We know patients, they are group of patient adult with HFrEF, NIA class 2 to 4, ejection fraction 40 or less, and we're receiving appropriate treatment and the guideline medication. Okay, and also the ARNI was around 20%. What is the intervention? It is an empagliflozin 10 milligram, and the comparison is placebo matched, and the outcome is the composite endpoint of decreased cardiovascular death and heart failure hospitalization. Was the assessment assignment of the patient of the treatment randomized? Yes, it is permuted block randomization, so it is like double blind, where the group similar to at the start of the trial. Yes, the groups are equal and fairly balanced. Underrepresentation of women about 25%, and blacks is around 11%, and the ARNI is around 20%. Aside from the allocated treatment, where the groups are equally treated, yes, I think, do you agree with this? And where all patients were entered of the trial accounted for, yes, where they are all analyzed in the group which they are randomized, intention to treat analysis, yes, where randomized, where measures objective, or where the patient and the clinician were kept blind, yes, double blind, yes. And the objectives are death and hospitalization as a solid endpoint. And how large and precise was the treatment effect? Yes, it is about 25% reduction in the endpoint and mainly in the heart failure hospitalization. However, the mortality is around 8%. And if you compare this to DABA-HF, the mortality rate is less, is affected more in patients with DABA, but this because the DABA, they are lower risk and not having high BNP like those group. Well, the result helped us to caring of our patient. The external validity, yes, EMBER reduced provide a new evidence of SGLT2 inhibitor in patients with more severe heart failure compared to prior trial as the DABA-HF, and updated meta-analysis of the evidence for SGLT2 is needed to formulate the role of clinical practice. Thank you. And this is only just I made that comparison between EMBER reduced and DABA-HF. The DABA-HF is usually they have lower NT-proBNP and they have only 10% given liberalizing inhibitor. And this is outcome is almost the same, and we are waiting for the more completion of the DABA PRESERVE trial next month, inshallah. Okay, thank you.
Thank you very much for this very thorough review of the role of this agent in reduced ejection fraction. I think we move on now with Professor Kamal Ghalayini, Emperor Preserved Historical Win Against a Formidable Foe. So looking at SGLT2 inhibitors across a broader range of ejection fraction. So over to you, Dr. Kamal. And there are some questions that are popping up in the chat, but I think we'll hold off and have a discussion with all the faculty at the end.
Thank you very much. Thank you very much, Mr. Chairman. Thank you very much, Dr. Faiz, for this beautiful introduction to the HFrEF world. And Bismillah wa salatu ala Rasulillah, Allahumma salli wa sallam ala Sayyidina Muhammad. Shifting gear now towards heart failure with preserved ejection fraction. And okay, and looking at this aspect first as a whole, and then through the Emperor Preserved trial. This is my disclaimer. I'm a speaker for BI, and let's start with the unmet need. So, under the new definition, we all encountered late last year about heart failure and the changing of mid-range to mildly reduced ejection fraction when we talk to 41 to 49 and adding the improvement element arm. I think this is a beautiful hope for us and our patients that we're talking about improvement right now. We know that it's still in a limited, but at least it is in the scope. We look at that. We look at the heart failure, the preserved ejection fraction patients, and we see that they suffer from a poor outcome. There is no clinical proven therapist for them. We see that hospitalization is still number one, especially for those patients above 65 years. 50% of them are with preserved ejection fraction. 30% of those patients will unfortunately die within 1 year. There is no clinical proven therapist until very recently, and treatment option was limited, as we are going to see. The more we know and the more we understand about the preserved ejection fraction pathology and pathophysiology, the more we see that we're diagnosing more and more patients. And this is a simple diagram that shows there is an increased number of preserved ejection fractions towards the reduced ejection fraction being recognized. And this is quite an old slide, and I believe it would be much more now as we understand the disease more and more. Now, mortality is a little bit less, but we're comparing, bad to worse or worse to bad. With the preserved is 29% and the reduced is 30%. It's still a big killer disease, unfortunately, and more of a malignant disease that is racing with cancers and taking their patient's life. And with the 5 years mortality, the number really is very high. So what about other cardiovascular diseases? We have the atrial fibrillation as one of the most common arrhythmia diseases. We have the stable and the hypertension and the reduced ejection fraction. We see the number of proven and evidence-based medications and treatment available for all these 4 diseases, in compared to a very weak scientific support for the preserved ejection fraction patients. And from that point, that 2021 recommendation would be for mildly reduced ejection fraction, shifted towards the reduced ejection fraction, because this is where the evidence come, although that level of evidence is C, but it's still there, and it does some benefits for our patients. So the recommendation would be for the preserved ejection fraction, extremely limited, as I mentioned, with a class 1 indication, but unfortunately the level of evidence is C, is that keep looking for risk factors, keep treating it, and use diuretics whenever the patient is symptomatic. And unfortunately, this is not much to do, because we're doing this anyway, if there is a heart failure or not. And adding a diuretic is really not much when it comes to mortality, as we don't have any evidence for that. But let's shift to the EMPEROR program. Now, Dr. Faiz elegantly presented the details about EMPEROR reduced, and it was presented on the 2020, and I will be touching on the EMPEROR preserved, which was announced a year later, and then we will have more of the EMPEROR programs to come. But all these started about 7 years ago with the EMPERIC, where it was a breakthrough introduction of this molecule to the world of cardiovascular disease, and in terms of prevention and management. Adding to the list this important so empagliflozin heart failure with preserved ejection fraction, an original article that was published in the New England Journal of Medicine in the late 2021 by an international team. It was announced in the digital experience on the same year, actually the same date, in the European Society of Cardiology. It's a straightforward trial, phase 3 in a double-blind placebo control, with almost touching 6,000 patients, and randomly spreading them into 2 arms, the empagliflozin arm and the placebo arm. And the composite primary endpoint was the first event for educated cardiovascular death or heart failure hospitalization. And we have another confirmatory key secondary points, which is the first and recurrent adjudicated heart failure hospitalization, and the slope change of the GFR. We'll come into details on all of these. But look at the exclusion and inclusion criteria. We can see that for the first time, we're touching a GFR of 20, and this is quite low for any of the other anti-failure medication that we have here. The inclusion was straightforward, 2 to 4, and we will look into details about the ejection fraction and the BNP and the structure changes. So these are the 3 points that we're going to discuss right now. The primary endpoint, which is the adjudicated cardiovascular death or hospitalization. Secondary endpoint, which is first or recurrent hospitalization. And again, another secondary endpoint, which is the GFR slope change, and all of these are confirmatory. Now, looking at the 2 arms, women are equally distributed, and it's becoming now mandatory to look at that, because historically we've seen that a lot of our landmark trials really did not appreciate the presence of the gender difference, and most of the patients there were male. So this is a nicely balanced trial. When it comes to the respect to gender, we can see that most of the patients are in the class 2 New York Heart Association classification. We do have some on class 3, but less and less class 1 and class 4. The BMI is 29 to 30-ish, and this is actually more or less of our patients' profile. Now, what about the distribution of ejection fraction? You can see that most of the patients, most of the patients are distributed almost equally in the range of 1,000, more or less, and in all 3 areas: 40 to 50, 50 to 60, and 60 and above. And this gives us actually a good tool to compare and determine where to put our patients in this part. So, continuing the characteristics, BNP is again more or less equally leveled in both arms. We have more of a non-ischemic cardiomyopathy, but a respectable number of ischemic cardiomyopathy. And hospitalization again is there, and then diabetic and non-diabetics are there. So we're almost equal in diabetic and non-diabetic patients in terms of both arms, the IMPA arm and the placebo arm. What about the GFR? Less than 60 in 50% of patients, which is equally. And then we can see that the RAS medication plus minus ARNI group is again presented, and you can see that most of the patients are on beta blocker and quite good number on statin or the less digoxin and aspirin. And this is the spread that we see, because if you remember that almost 2/3 of the patients were non-ischemic cardiomyopathy. That's why we can see the number of aspirin is not high, and this is expected. Now, efficacy outcome. There is a 21% relative risk reduction in the composite primary endpoint of cardiovascular death. Now, this is very good. Number to treat is 31 patients. And the impressive part is the early separation of these two curves. And all this comes under the statistical significance of p-value of less than 0.001. So first point checked, 21% relative risk reduction, and a p-value of less than 0.01. What about this secondary endpoint, which is also a confirmatory endpoint, and it looks at the heart failure hospitalization. Where is it first or is it recurrent? Actually, the number is even better. We have a 27% of relative risk reduction with the same statistical power, statistical significance, and all in favor of empagliflozin. You can clearly see the area under the curve in both arms, the placebo and the intervention. So checked for the secondary endpoint, the first part. Let's look at the third part of the endpoints, the second confirmatory endpoint, which is the effect on the kidney. We practice a complicated syndrome more than a disease. We're treating chest because of the heart, and at the same time we're looking at the kidney. So it is quite a challenge for the whole team, including the family and the caregivers. So kidney is a very important part when we look at heart failure management as a whole. And giving any medication at any time, although we keep an eye on all the other parameters, but there's always a very strong indicator when the kidney starts shaking or the GFR deteriorates. And in the Emperor Preserve trial, it was shown that there is a reduction of deterioration. And this line is where the deterioration of the placebo group and actually, it's the opposite, sorry. This line is the deterioration of GFR of the placebo group, and this one is the deterioration of the intervention, which is the EMPA group. And we can see that there is a preservation, some sort of preserving the deterioration, in which it protects the kidney from this horrible reduction. And when we're all talking here about an ejection fraction of more than 40%, 40, 50, 60, we used to say this. I mean, look at now, most of our patients and our dear colleagues will look at the ejection fraction and say your heart is fine. And we're talking about people with good ejection fraction. So it is it is a safe drug. It is a drug that protects the kidney with a statistically significant p-value of less than 0.001. So the secondary endpoint regarding the GFR slope is confirmed, and all the p-values are nicely presented in a very good statistically significant figures. What about the safety outcome? Well, actually, overall safety profile of the EMPA was comparable to the previous finding in the cardiovascular patients. Remember that this study comes 6 years, almost 6 years from the EMPA-RIG, so there is a very good number of experience for that patient, for that molecule. So it is safe, and this is just to prove the proven. So hypotension is again non-significant increase. UTI is numeric only increase, and genital infection are there in a numeric increase, but they rarely lead to discontinuation of treatment, and they rarely need hospitalization. But honestly, we have to tell our patients, we have to tell, our heart failure nurse that any patient on SGLT2 inhibitor needs to be always reminded about the UTI symptoms and genital symptoms. And we have to keep some sort of, I don't know, it depends on the center, but some sort of an open channel for those patients. Whenever they develop this, they have to inform us so we can assess first and then treat, because it is not really wise to just stop the medication and denying the patient all the benefits of this medicine. What about the hypoglycemic effect? It's extremely safe drug when it comes to type 2 diabetics, and thankfully we have passed this dilemma with our colleagues, the pharmacists, because we really was facing an issue with asking the patient, are you diabetic? No. So why is your physician writing you a medicine for diabetes? It's a strong medicine. You have to go back to him. But alhamdulillah, we've passed all this. So what about the selected adverse event in terms of numbers? So the hypotension, as you can see, it's 10% towards 8.6%. The symptomatic hypotension is even less and less significant. Ketoacidosis is more or less the same in diabetic, in both arms. Hypoglycemic effect, again, non-significant, and UTI and complicated genital infection is almost the same. So this is an interesting exploratory outcome of new onset diabetes in patients of heart failure with ejection fraction in patients who are pre-diabetics, and we can see that there is no significant increase in this chance of developing diabetes on this medication. Now, empagliflozin treatment lead to improvement of several vital signs and laboratory findings, whether hematocrit value, whether blood pressure in hypertensive patients, whether the glycosylated, definitely the HbA1c, it will be improved. So thinking about adding this element for a patient with heart failure with preserved ejection fraction with risk factors that we know, like hypertension, diabetes, will really be an add of benefit to their regular treatment. What about our quality of life, Kansas City Cardiomyopathy Questionnaire. And again, there is an improvement on treatment, and all data, there is an improvement with the intervention of empagliflozin. And all this has been observed from week 12, around 3 months, and you find that your patients are happy with it, thankfully. So let's look at the wider context. The first, the Emperor Preserved is the first prospective outcomes trial for HFpEF to robustly meet the primary endpoint, and we can see that a number of trials that has been done before, unfortunately, the best was the Paragon with the empagliflozin, with sacubitril valsartan, and it was nearly touching to be a positive trial, but there is a lot of strong sub-analysis items in it. But look at the empagliflozin compared to the other ones. I mean, it's clearly off way when it comes to outcome. What about the ejection fraction? This is just a reminder of the few slides that we go through. So Emperor-reduced empagliflozin met the 3 endpoints, whether it was primary or secondary endpoints. And again, as I mentioned before, the p-value was significant on 3 of them. And it is overall a good drug when it comes to cardiovascular death in all spectrum. But you can see that the more the ejection fraction is higher, the less effect. So up to 60%, you have a very good results, but when it comes to more than 60%, it's not like less than 60%. And this is again another look at the effect of cardiovascular death, and there is not a significant between patient with whether reduced or preserved ejection fraction. It's more or less the same. And just a reminder that in Emperor Preserved, there is a 21 reduced in overall patients, and 29% in patients less than 50, and 17 in more than 50. That's when we're talking about mortality, cardiovascular mortality. And this lines looks at the ejection fraction really didn't impact the effect of much of the empagliflozin in terms of death, although there is increase, but it's really within the context of the desired targets. And this is again the secondary endpoints. Again, it is a little bit increased when it comes over 60, but it's still within the desirable targets. Again, the GFR part, as I mentioned before, whether the ejection fraction was less or more than 50, we still have a good preservatives, a good protective role for the EMPA part. And again, this is another demonstration of less and more than 50% of ejection fraction when it comes to the protection of kidney. So there isn't much difference, and the p-value actually was not significant in terms of the difference. So in conclusions, there is a reduced and primary composite endpoint for cardiovascular death. The benefits for the endpoints were consistently observed across the ejection fraction, and when the Kansas City and the ejection and the GFR slope were benefits were observed even less for this and for less and for more than 50% ejection fraction. Now, in a glance, the summary, last slide for the summary. Half of our patients are having preserved ejection fraction, although they have a poor outcome from whether it was a cardiac or renal outcome. And the Emperor Preserved actually is the first trial in medical history as it's shown that there is a beneficial outcome in patients with preserved ejection fraction when it comes to cardiovascular death or hospitalization. As a reminder, we have a 21% relative risk reduction when it comes to death. We have a very good evidence for kidney protection. We have nicely shown that whether the ejection fraction was less or more than 50 across the spectrum, the molecule and the drug works either ways. And we believe that empagliflozin is now changing our practice and our patients' life, alhamdulillah. With that, Mr. Chairman, dear colleagues, and my dear audience, thank you very much for your attention. And Dr. Mervat, the screen is yours.
Thank you again, Dr. for presenting all the data here. And we'll move on to our final speaker, Dr. Musa'id, who will discuss the IMPULSE trial, empagliflozin, a winner in challenging arena of stabilized acute heart failure. And then we open to discussion, inshallah.
Thank you, Dr. Mervat. Let me start by sharing my slides. Okay. So Dr. Faiz and Dr. Kamal made my job a bit easier because they talked about the heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. However, one of the most important points, actually, if you read the data and look at the trials, is do SGLT2 inhibitors actually work in acute heart failure? And I'm gonna show you why this is actually an important point. So just a brief definition. So we know what acute heart failure is: a rapid or gradual onset of signs and symptoms of heart failure, which lead for the patient to seek urgent medical attention, either an unplanned hospital admission or emergency department visit. And we face this all the time. Like most of us in our hospitals, whenever we are covering the emergency room for consultations, or whenever we admit patients, usually they come in with acute heart failure. And acute heart failure is the leading cause of hospitalization in patients above the age of 65. The problem with acute heart failure is, if we look at the natural history, whenever patients present with acute heart failure, usually what happens is we treat them, and then their course, they will stabilize a little bit, and then eventually they will come with another decompensation, and then they go back to a baseline, which is not similar to the previous baseline. And then they have another decompensation, and then they improve a bit, decompensate, improve, and eventually they either die or proceed to go with advanced heart failure therapies such as assist devices and transplantation. And the problem with acute heart failure is if you, in the initial stage, you just care for them a little bit. However, when they progress and they have recurrent hospitalization and ER visits, they require a lot of care, which will impact our resources and increase the cost for the healthcare systems. So we can see here that each acute heart failure hospitalization is associated with worsening outcomes, and it will lead to a problem with our resources and even the healthcare expenditure. So one of the studies looked at repeated heart failure hospitalization, and perhaps the most common risk factor for repeat hospitalization is previous heart failure hospitalization. And we know that if the patients get readmitted with decompensated heart failure or with acute heart failure, that their survival started to decrease. And the more heart failure rehospitalization they have, the worse survival they have and the worse prognosis they have. So we know in the most recent guidelines that ARNI, beta blocker, MRAs, and SGLT2 inhibitors are the recommended therapies for heart failure with reduced ejection fraction. And if you, I did not put the data just to save time, but we know that the number needed to treat with these medications to save one life is only 3.9, which is an amazing number that we don't see in most trials. With that, patients, the recommendation, this is the ESC guidelines from 2021. We can see that all of these therapies received class 1 indication for HFrEF with a level of evidence A, with exception of sacubitril valsartan, which was B, because it's only from one randomized trial. And however, if you look at these trials and just look at them in details, for example, the Paradigm-HF, which studied ARNI in acute heart failure, we see that one of the key exclusion criteria was current acute decompensated heart failure. And also the Emperor-reduced trial, we can see that also one of the key exclusion criteria was acute decompensated heart failure requiring IV diuresis or inotropes or vasodilators. Again, with the Emperor-preserved trial, we see that one of the key exclusion criteria was acute decompensated heart failure. So that's why whenever we present the data, or when working in the hospital doing rounds, seeing a patient with a new onset heart failure or a patient who's admitted, one of the most common questions we get to ask is like, why are you starting ARNI or SGLT2 inhibitors in the acute setting, whereas the trials actually, they did these, started these medications in the outpatient setting when the patient is stabilized. So the question is there any evidence for SGLT2 inhibitor and ARNI in acute heart failure? So in the old days when the first, the Paradigm-HF came, and then the DAPA-HF came, and Emperor-reduced came out, we as heart failure people, we started using these medications in the acute setting. However, we were not backed with data. However, now we do have some couple of key studies that looked at this issue. So if you look at quickly on ARNI, I know this talk is focused on SGLT2 inhibitor. So however, I'm gonna go over ARNI quickly. The Pioneer-HF trial did study sacubitril valsartan versus enalapril in patients who are hospitalized during in-hospital, like an admission with acute heart failure. And basically what this study showed, I'm going to skip over it quickly, that there's significant difference between sacubitril valsartan and enalapril with regards to the change in BNP. And then when they did some secondary analysis, there was also reduction in hospitalization and worsening heart failure events. So with that in mind, we started using ARNI in acute heart failure, in the acute heart failure setting. And there was really no significant worsening, like side effects with in-hospital initiation with ARNI compared to ACE inhibitors. However, with that in mind, we still have a very bad problem with acute heart failure patients. There's an urgent unmet need to improve their outcomes, because as I demonstrated in the beginning, or as I said in the beginning, their heart failure is the leading cause of admission in patients, especially older patients. And the other major problem with hospitalization with heart failure, unfortunately, not everywhere they have specialized heart failure clinics where they up-titrate their medications, and not everywhere they have clinics where they actually are aggressive with up-titration of guideline-directed medical therapy. And there are many studies that showed that in-hospital initiation of guideline-directed medical therapy was associated, or was the best predictor of long-term adherence to these medications. And we see that all the time. So I usually say to the fellows who are with me, like, if you don't start these medication when the patient is hospitalized, most likely they will not be started in the outpatient settings. Dr. Kamal and Dr. Faiz beautifully demonstrated that Emperor preserved and Emperor reduced trial, and from these trials, it showed that there's early benefit for SGLT2 inhibitor, namely the empagliflozin, with regards to clinical benefits, and these clinical benefits appeared early and as fast as within 14 days of initiation. So the question that we have now, is there any evidence that in hospital initiation of our SGLT2 inhibitor, and we're talking specifically here about empagliflozin in patients with acute heart failure, led to better events? So luckily, this was studied in the Impulse trial, and the Impulse trial was just published, I think, a couple of months ago in Nature Medicine. And this trial was studied the effect of empagliflozin in patients who are hospitalized with acute heart failure. And I'm going to present it or go over the details of this trial because I think it hasn't been, it was just published recently. So basically what they did, they randomized 530 patients with acute heart failure 1-to-1 to empagliflozin 10, which is the dose we use in heart failure, versus placebo. And what they they followed them up to 90 days. And what they looked for, or primary endpoints, were death, number of heart failure events, and we're going to talk about this a bit in details, which include heart failure hospitalization, or urgent heart failure visits, and unplanned outpatient visits, time to first heart failure event, and the change in the Kansas City questionnaire, which usually reflects the well-being of the patients. So the key inclusion criteria that the patient needed to be hospitalized for acute heart failure, and they didn't need to be patients who are known to have heart failure. It could be de novo. So either we have de novo hospitalization or chronic heart failure patients. They need to be stabilized. I'm going to go over that in a bit. And they needed to have evidence of heart failure. So basically, they needed to have elevated BNP, and these are the numbers that they included in the trial. And the patients needed to be on IV diuretics. So the patients who are treated with oral diuretics were not included. The exclusion criteria were cardiogenic shock, so severe hypotension, heart failure triggered by secondary causes such as acute MI. So patients who come with acute STEMI, with a STEMI and they develop heart failure, they were excluded. Patients who are undergoing procedure were also excluded. Patients with prior ACS or stroke within the 90 days were excluded. GFR below 20 were excluded, and this goes with all the EMBER trial. And type 1 diabetics were excluded. So keep in mind that SGLT2 inhibitors for now are not approved for eGFR below 20. So the lowest GFR we can use with empagliflozin is 20. And with DABA is 30, and these medications are not to be used with dialysis patients or type 1 diabetics. So how did they define acute heart failure? So the patients needed to have symptoms, so they needed to have dyspnea, and they needed to have signs and symptoms, signs of decompensation, and they included 2 of these signs. So either X-ray findings, auscultation, chest auscultation, there are crackles or rails, and edema on physical examination, and elevated JVP. So you needed to have 2 of these to meet the criteria on top of the inclusion criteria we mentioned about, before. And what does stabilized mean? So in order for you to be classified as stabilized, you need to have a systolic above 100 with no symptoms of hypotension in the preceding 6 hours. They need to be no increase in the IV diuretic dose for 6 hours. And there needed to be no IV vasodilators, such as nitrates, within 6 hours. And also, you need to not be on inotropes within 24 hours prior to randomization. Again, the primary endpoint was the composite of death, a number of heart failure events, and which we talked about after 90 days. And they had some secondary endpoints, which will also go discuss them in the next few slides. So let's take a look at the baseline characteristics. So if you look at the baseline characteristics of the IMPULSE trial, they included, again, 530 patients. Half of them were in the embedded group, and half of them were in the placebo group. Age was 71, so, and this is reflective of the typical heart failure patients we usually see. 30% were women, and this is lower than EMBER reduced. Majority were whites, and majority were randomized in Europe and North America. The NYHA functional class, majority were NYHA functional class 3, and some are 2. And some people will ask, like, why would you admit a patient with NYHA functional class 2 to hospital? So these are the NYHA functional class at randomization. Some of the patient came with bad symptoms, then they improved. BNP, the NT-proBNP, the average was 3,200, and majority of patients had a good blood pressure of around 122. with a BMI, majority of them were 28 to 29, so mostly obese. If you look at the GFR between the two groups, it was equal, around 50 to 54. However, 27% of the patients in the EMBA group had GFR below 30. So this tells you that this medication is very safe in the lower GFRs. However, we should not use it in acute kidney injury, and we should not use it in patients who have a GFR below 20 or on dialysis. The average ejection fraction was 31%, and 70% had HFrEF. However, around 30% had ejection fraction above 40. So it doesn't matter if your ejection fraction is reduced or preserved. Patients can be included from both groups. 70% were de novo, were decompensated from a chronic heart failure patient status. However, 30% were also de novo. Medical history, we're not going to go over it. Basically, it was equal in both groups. And if you look at the baseline therapies, 70% were on ACE inhibitor or ARNI. MRA was 57%, which is low. However, it's better than most of the other heart failure trials. Usually have an MRA of around 30%. And this tells us how underutilized this important medication is. 80% were on a beta blocker, and 5% were on a loop diuretic. So let's look at the efficacy outcomes. So if you look at the efficacy outcomes, the trial used what they call winner ratio. So because of the low numbers, it's difficult to, usually if you look at the EMBER reduce and EMBER trial, EMBER preserved, they included thousands of patients. However, in the EMBER in the Impulse trial, we had only 53%, and they used the win ratio for analysis. And basically, they count each event on each group and each patient, and they see which was a winner, either empagliflozin or placebo. So overall, the net clinical benefit, there was a statistically significant difference in between the empagliflozin versus the placebo, where the 54% of patients achieved clinical benefit with the empagliflozin. And this was reflective both in time of death and heart failure event frequency. So if you look at the time of death, there was more benefit with empagliflozin compared to the placebo. However, I have to say that this trial was not powered to look at mortality. And if you look at heart failure events, also EMBA was a winner. And if you look at the symptoms or benefits with regards to the Kansas City questionnaire, also there was a benefit with empagliflozin compared to the placebo. So overall, there was a reduction in mortality with the empagliflozin compared to placebo. And there was an improvement with regards to heart failure events with empagliflozin compared to placebo. And this was seen across all subgroups. So if you look at either patient de novo or decompensated, although here it's across the midline, there was some more benefits with empagliflozin. So either de novo or decompensated heart failure. And also if you look at with regards to ejection fraction, there was also benefit. However, it was mainly more seen with reduced ejection fraction compared to placebo. And we see there's time to cardiovascular death. So the study, we have to keep in mind, it's still underpowered and only went to 90 days. There's no major difference between the two. However, we can see that the curves start to separate with time. So it will be interesting to see the follow-up data. And we see that there's a difference with regards to the Kansas City questionnaire, where empagliflozin, patients on empagliflozin felt better. And also we can see that patients with empagliflozin achieve more body weight loss compared to placebo. And we know that weight loss is a marker of decongestion, and it's been shown in multiple trials that weight loss is associated with better outcomes. So again, empagliflozin showed there's significant difference between it and placebo. And there's really no change in eGFR between the two groups. However, keep in mind that this trial only went to 90 days, so it's not, we don't have long-term follow-up. Is the medication safe? So luckily, we have really, as Dr. Kamal and Dr. Faiz showed, we have really good data with regards to safety. And this trial also showed basically the same. There's no difference between empagliflozin and placebo with regards to adverse events, either leading to medication discontinuation or serious adverse events. And maybe placebo had more side effects compared to empagliflozin. And we can see it again with all the worrisome outcomes. So there's no difference in ketoacidosis, no difference in UTIs. And this is a problem that prevents a lot of people from starting SGLT2 inhibitors, which unfortunately is not founded, honestly. So if you look at Emperor Reduced, Emperor Preserved, even DABA-HF and the Impulse trial, there's no difference in UTIs between the two groups. So with that in mind, try and, as much as you can, to use these medication. No difference in hypertension, volume dilation, hypoglycemia, or major genital infections. And these are just a table representation that shows the actual figures. So basically, summary, what did Impulse show? Impulse showed that patients who are treated with empagliflozin after they have been hospitalized with acute heart failure, either de novo or as a decompensation of a known heart failure, they were 36% more likely to experience a clinical benefit. And this clinical benefit was consistent across all ejection fractions and whether de novo or not. And what's more important is that we know that empagliflozin was actually very well tolerated, no major side effects, and really consistent with the previous trials of all of empagliflozin, which showed that there's really good clinical benefits with no concern with side effects. So with that, I'm gonna thank you, and I'll yield back to Dr. Thank you so much, everybody.
Well, I want to thank you all for these incredible talks that were very useful. And I'm going to just start shuffling some of the questions that did come in. And please, all of you, feel free, Dr. Kamal, Dr. Faiz, Dr. Msaad, to answer whichever you feel. I'm not going to exactly pick names. So one of the obvious questions that did come up and always comes up is there are new 4 pillars for the management of heart failure. So how do you, in your practice, start these patients? Do you start them all at once? Do you graduate them? I'm sure you.
Okay. Okay. There is 3 ways of starting the medication. The old way is the conventional way of starting the one medicine at a time, then increasing the dose and start the other one. It takes about 6 to 1 year to reach to the maximum tolerated dose or the guideline dose. This is the old way of conventional management of heart failure. The new way is to go for comprehensive management, and this comprehensive management is to start as soon as possible with a small dose of each one, and then titrate gradually over a few weeks, 6 weeks or 8 weeks. And the latest medicine is the condensed way. Condensed way start at the SGLT2 or beta blocker, then adding ARNI and aldosterone, and all 4 is finished, and you reach to the maximum dose in 4 weeks. So this is a condensed way. So nowadays, our once we diagnose the patient with HFrEF, we give the small dose of each drug, and then we follow them shortly in order to titrate as if in 4 weeks we can reach to the target doses of each group of drug.
And maybe I'll add, maybe I'll add, Dr. Faiz, thank you. What I usually do, so it depends on where I see the patient. So if the patient is admitted with acute heart failure, what I usually do, I start all 4, especially like during their hospitalization. So what I usually do, in the first day when I see them, I put them on diuretics, and then I start ARNI if the blood pressure allow, or an ACE inhibitor if the blood pressure does not allow, and this will help with afterload reduction. And within a day, I usually start SGLT2 inhibitor and MRA within a day or two. And before they get discharged, I put them on beta blockers. So you can start all four within 3 to 5 days, which is the usual length, or within a week, which is the usual length for usually for a new onset heart failure patients. And then whenever I see them afterwards in the clinic, they're already on maximum SGLT2 inhibitor because it's one dose. They are already unusual maximum MRA because spironolactone is usually 25 and it's one dose. And then what I usually do, I uptitrate, if they're compensated, I uptitrate beta blocker first, because we know that there's more benefit of uptitrating beta blocker compared to ARNI. So we usually uptitrate beta blocker because there's a major difference in beta blocker dose response compared to ARNI, and then go with uptitrating ARNI. So hopefully within that, it will be a few weeks, maybe 2 months, 3 months, and they're all on maximum doses.
I have a small addition. With what we see in the practice, it is extremely important that the patients are very well educated about this, about the way the medication is going to work, why are we doing this, and what is the importance of giving medication even without symptoms. Because unfortunately, when they go for second opinion, or they'll delay the day, coming back to the clinic, and they're ending up with an advice that you're good, there's no need for all 4 of them, let's cut 2 and keep 2, and all other unfortunate advices. So putting the patient on board, supported by the caregivers, will really maintain the effort that we all do, whether it was as an inpatient like Dr. Mus'ad mentioned, or like Dr. Prof. Faiz mentioned also in the other group, which I totally agree.
I'm going to ask a question that's maybe a little provocative, and again, I think it's nice to hear from all the experts here. So, when we say start all 4 during hospitalization, there's some who will be hypotensive. So I think hypotension is the main concern of all clinicians, and that's why we try to graduate it, particularly with patients who have come in with heart failure. But many administrators are concerned about length of stay. And actually, length of stay is a key performance indicator, and perhaps in the public sector, it's only a key performance indicator. But in the private sector, it is costly to keep a patient in the hospital. So how do we balance those when we're trying to serve our patients by starting all the medications, up-titrating them? How do you do it clinically in your practices, and how do we go forward with this?
Very
What a
difficult
tough question.
Yeah, it is very difficult question, and every patient is a case by itself. So we are tailoring our therapy according, and it is. I believe in in tolerated dose more than the guideline medical dose. So you start, every patient is different. We have one patient discharged only on 20 milligram Lasix. Some people, they cannot tolerate anything, but it is a different scenario for each patient, and I think the maximally tolerated dose start gradually, and then a frequent visit. That's why the walk-in clinic or the heart failure program is done to see the patient more frequently in a week or few days until you reach to the maximum dose every week until you go to 1 month. So it is a very difficult question, and then I want to hear from our expert here. Dr.
Maybe I can add, thank you, Dr. Faiz, thank you, Dr. Mirfat. So I think how I look at this is a very common problem, especially if you see a lot of advanced heart failure patients. So sometimes you see somebody with an ejection fraction of 10%, 5%, they're really sick. I think you have to look at, do actually some of these medications, do they actually, some people fear that they cause a lot of hypotension, but sometimes actually, if you look at the mechanism, you will see that actually most of the time, if you start these medication, actually from a hemodynamic perspective, and I see this when I put a Swan-Ganz catheter in them usually, so especially very ill patients, look at the data. So for example, MRA has not been shown to cause hypotension. If you look at the trials analysis from Emphasis, it did not show there's any difference with regards to blood pressure across all ejection fractions. So usually I don't worry about hypertension in this setting. The other thing is SGLT2, they don't usually cause that much hypotension, so we usually don't worry about it. Perhaps the biggest problem with the guideline-directed medical therapy is the ACE inhibitors, ARNIs, and what do they do? So I think what I usually say is just try it. So because you never know what your patients will do. If you're really concerned, let's say your blood pressure is above 90, then probably I would drop the ARNI, start small dose ACE inhibitor and see what happens. And you will be surprised sometimes with that when you start an ACE inhibitor, their SVR will drop and their cardiac output will improve and then their blood pressure will improve. So I think what I usually tell people, just try it, see what happens. And if you try the patient flies, that's great. If they don't fly, then think about what you're gonna do. If they run into a problem with consistent hypotension, especially if they're symptomatic, then you have to think maybe your patient is very sick and they cannot tolerate anything.
I need to add something, please. Dr. Amirdat, add also the renal impairments that, the creatinine keeps creeping because we're dehydrating the patient. So you have creeping creatinine. So if you want to add MRA or blocker, then you're afraid from the creatinine. From others, they're afraid from hypertension, and the patient is not very well stable. So you'll be thinking 3-4 times before adding or increasing the beta blocker. It is a dilemma. I totally agree with Professor Faiz and Dr. Masad about treating case by case, day by day, and all that. But the thing is, we're not keeping our patients to up titrate or even to start the medication for them. We're keeping them to offload them. Once if they are offloaded and we have a good follow-up in the clinic, so it's better for them to go out. And sure, it is always, start a medicine is quite safe under your eyes in the hospital, but this doesn't really take much time because we start immediately after, or let's say the next day after stopping the IV diuretics. But then the extremes is the big dilemma. And when you come to an end stage, just like Dr. Musab was saying, a very low ejection fraction, the critical patients, we know that the cost is very high, the length of stay is unpredictable. The response, I may also echo Dr. Masad's comment, is totally unpredictable. So for most of the patient, statistically, probably 95% of them, we offload them, start them on some medication and continue everything in the clinic. But for the last 5%, Allah musta'an.
Yes.
So you cannot avoid this early discharge. However, we have to have a discharge list criteria. And if we can create a day unit, heart failure day unit, they come for a stay for a few hours and then go home at the afternoon, it might be cost effectiveness. But we are in tertiary care hospital. We have a lot of sick patients of 10 and 5% and going for heart transplant, like Dr. Musad say. Sometimes it takes weeks, and we have the long weekend. Sometimes it's an endorsement from one team to other team. It is very difficult to just. That's why cost effectiveness has to be there in the quality of management. I don't know.
But honestly, honestly, as we always endorse and really emphasize, the art is not getting them out. The art is protecting them from admitting. Now, this is the whole thing. This is what we do as programs for heart failure care. Once a patient is admitted, khalas, the rule is no more there. But the more you keep the patients outside the hospital, whatever you do, just keep them outside the hospital, the more they are in a safer environment. But once the admission is in, things really goes always.
It is not a good practice to just discharge the patient today and readmitted again and after a few days. It is if any readmission within 1 month, it is a morbidity. Because I heard one of the cardiologists, I discharged 10 today and 9 admitted on second day. What is that?
Yeah, so I think part of it is, yes, appeasing the administration and the policies and so on by minimizing readmissions, which hold us hostage as clinicians. But really, pushing all of that aside, it's giving your patient his or her life back. They don't want to hospital all the time. They want to have a life. They want to be with their families. They want to be able to enjoy Ramadan, Eid, what have you. So we're actually helping our patients by keeping them out to enjoy life. But if every second week they're hospitalized, we're failing our patients, not just the system. And I think more than a discharge checklist, it's perhaps a discharge plan. So after the patient leaves, what are we going to do? Where is he or she going to go? Are they going to go to a clinic? Are they going to go to a day unit? And if they do, what's our plan? Are we planning to increase the dose of this drug over because this patient behaved differently with potassium, for example, and what have you? I'm going to move to a different area that was discussed today, and it was again the use of EMPA in preserved EF. We just discussed heart failure and acute heart failure and so on. Preserved EF, we've seen these patients, they come overloaded, but they have a preserved EF. Sometimes they're overdiagnosed and it's not really heart failure, and sometimes they're underdiagnosed. Just because they read the EF as an absolute number on the echo report, the assumption is this is not heart failure. And finally, there's some light at the end of the tunnel, Zemegulu, with having a trial that perhaps put a drug that we can use. So maybe I'll, again, please go around and feel free to kind of give us your feedback. What are you doing with these patients? How are you starting these empagliflozin, and what doses and so on?
Okay, maybe it's going to start from me. Okay, Mervat, and we said that maybe 5% they go bad or 4% they go bad and reduce ejection fraction. Unfortunately, in preserved ejection fraction, it's much more than that. The rate of failing the diuresis, the rate of reaccumulating the fluids, it's totally, when it's there, we don't have a lot of options to do. I mean, empagliflozin is great. We add ARNI as well. And sometimes we have to give the full-blown 4 pillars for somebody with ejection fraction of 50, 60, not because of anything, but because we just, don't have anything else to do. And most of the time it fails. We put in mind the infiltrating microdoses, like, because it's on the floor now, it's in the road, in the red, and the radar. We control the dietary thing. Unfortunately, they all overweight, and the exercise is quite a big limit. But the more we see in our center heart failure in the practice, preserved ejection fraction, we've reached a time that we would pray that the ejection fraction is low, rather than to be high and the patient is overloaded. Immediately, and going back to your question, immediately empagliflozin is on board, good doses of diuretics, very intense education on salt and water intake and fluids and the dynamics of all this and what to eat, and hidden salt is the terminology that we keep saying for our patient. Look at the hidden, where is it hiding to harm you and to affect your life. Unfortunately, there isn't much to say except that, as you mentioned, there is a good light that's coming out. And also, we're using ARNI, again, if I may repeat myself. But that's all, unfortunately.
And maybe I'll go after Dr. Kamal. I agree with him 100%. It's a very frustrating subgroup of patients, and we're facing them a lot. And as Dr. Mervat said, sometimes it's overdiagnosed, it's underdiagnosed, because if you look at how you diagnose HFpEF, actually it's not just straightforward echo. We have, sometimes you need to do stress echoes, you need to do right heart caths, you need to do invasive hemodynamics with exercise. So it's not straightforward. usually, like whenever you see these patients, I try and look for reversible causes, amyloid, sarcoid. Sometimes you find something, sometimes you don't. Now with amyloid, we have tafamidis, but who can? It's very hard to get the medication. And then at the end of the day, I think for me, I made it very simple for these patients. Like the medical therapy is what I usually do. I just give them good dose diuretics. I started after preserved came out, I started using empagliflozin in these patients, even if they're not diabetics. And perhaps one of the most important medications that a lot of people are not using, and it has a lot of actually probable benefit, is MRAs, because if you look at the TopCat trial and some subgroup analysis and with the regional variation, there was a very striking benefit for MRAs with HFpEF. So for me, it's very simple: diuretics, MRA, and empagliflozin, and hope for the best.
Yeah, nothing to add. I think everything was said. Yeah, it is a disease of comorbidity, and we have to do typing of those patients and to differentiate not all comer to be diagnosed of these patients, to just classify them, those who had volume overload, or those who had like pulmonary hypertension patients, or those who had obesity, or those who had isolated diastolic dysfunction only and can be diagnosed by diastolic stress testing. And the management, luckily we have now diuretics. It is all diuretics like the Lasix and aldactone and empagliflozin, because also there is an evidence, very good evidence of empagliflozin or SGLT2, also the preserved is coming in the way, and patients getting improved with this diuretic option. We have the Paragon, and Paragon also showed that we can give up to 57% ejection fraction in both male and female, so it ranging to mid range at least. So we have I think there is a hope and there is a light on the road, and nothing to add. This is the way much before it was very difficult. Now I think we have some new evidence, which is very good. However, we have to stop unnecessary medication in those patients. Because beta blocker, for example, they cannot tolerate slowing the heart rate to less than 70. Usually we keep their heart rate around 70 to 80 because they need the heart rate. If you slow it more, you go to more congestion, except if they are ischemic, like the HFrEF patients. The hemodynamics, the blood pressures, they cannot tolerate hypotension, because if there is more, they go to more easily to hypotension and decrease the kidney function. So their pressure should be around 130, 140. This is very good. But they are needing treatment of their comorbidity and just the fine tuning of their medications. And once they become avolemic, just decrease the dose of the diuresis as much as you can, as rapid as you can. Okay.
Thank you. So I will ask another question. I know we've made the distinction between, we've discussed the use of these agents in non-diabetics. I mean, you use them primarily not as an anti-diabetic agent, we use them for heart failure per se. But is there a difference in the response of a diabetic and a non-diabetic to these agents? Have the studies shown a difference in outcomes in diabetics versus non-diabetics who receive these agents?
In the preserved, in the emperor preserved, it's extremely minimum. It's a little bit more beneficial for diabetic. Keeping in mind that most of these were non-ischemic cardiomyopathy in that trial. But in the clinical practice, it's more or less the same, when it comes to diabetic and non-diabetic. It's a bit challenge to start them for non-diabetics, right, to convince them. But otherwise, when it's on board, it goes smoothly. I mean, there isn't like a striking thing, at least to our limited experience.
And one thing, I agree with Dr. Kamal, and one thing we should probably try and change these days is we should not think about SGLT2 inhibitors as diabetes medications. And this is what I usually try and tell people is this is not for diabetes, okay? So it's cardiac medications, it's renal medications, and they're not for diabetes. Because if you look at the actually benefit in A1C with the SGLT2 inhibitor, it's not great. It doesn't reduce it like dimicron or the other anti-diabetic medications that don't do anything. So what I try and tell patients and teach others is probably these are not diabetes medications. And we see that there's no difference really, like diabetics, non-diabetics, but we see that the most striking thing is probably the cardiovascular protection and the benefits we see in heart failure, coronary disease, and even the kidneys, like the DABA-CKD came out, and there's striking reduction in mortality. And we're going to see also the empagliflozin trial was just stopped, and because it's strongly positive. So I expect the empagliflozin will show also similar benefits in kidney group.
Yeah, I agree with you totally that also in EMPA-REG, there is no reduction in hemoglobin A1C in those patients. And this is why they have a lock mechanism. SGLT2 work only when there is sugar is high. When the glucose is high, it work. If it is normal, it doesn't work, and they don't cause hypoglycemia. And we show the evidence in patients with diabetes and non-diabetes. And there is no hypoglycemia at all in our patients. It's just very rare.
So how do you deal with patients who question the use of these drugs for them and they're not diabetics? And how do you respond to pharmacies as well? Because unfortunately, we still do see that. So I think it is important that we address it.
Just discussion and give them more time. Most of our patients now are educated electronically. How do you call it? They go and they search for things and get these answers for us. On the other hand, there are patients who trust you, and a couple of words from you for them is the reference. But honestly, from the pharmaceutical part, from the pharmacist part, there is a great improvement, at least in the places that I work in. And that came after, a discussion and showing them trials and so on, and alarming them that this is really confusing the patient. I mean, we're all in the same boat. We all need, we are looking for the benefit of the patients. So discussion.
Yeah, and I agree. And one thing is also try and be proactive and not reactive, because try and anticipate what the pharmacist is going to tell your patient, what others will tell your patients. I had one guy, for example, he's 20 years old, who has HFrEF, and I put him on an SGLT2 inhibitor, and then his mother had diabetes, and she's taking the same medication. So there was a big mess. This is I learned from this. It was a couple of years ago, or maybe a year or two ago. I learned from this. He came to me and he's like, "What do you don't know how to treat people?" Is like, so I learned that you have to be proactive and explain it from the beginning, that what you're actually going to do.
What do you think? Your expert here, to tell the patient this is initially the medication of diabetes, now it is the medication for heart failure. And they tell him this is this. I told this, some patients who are not very well educated, I tell them this is an heart failure medications, and it is approved in the guideline. It is not anymore diabetic medication. So to convince them, because it is a discussion, I think, and if they believe in you, you can give it.
Yes.
I agree with you. Starting being proactive about the discussion, getting the pharmacists involved early, and getting them involved in the heart failure program especially is important. I think we learned, for example, from PCI when we were discussing antiplatelets, when we got our pharmacists involved early, the issue of adherence, the issue of discontinuation, and so on. Likewise with oral anticoagulants, once the pharmacists were invested in the project, it became a lot easier. And I think getting the pharmacists involved with this, because it is new for everybody. It's new for us as interventional cardiologists. It's new for the rest of the world. And that's why we're trying to extract all the expertise out of you. So I'll surkum as much as I can today. So again, now since I moved on to interventional cardiology, at what point and when do you have you decided that your patient is now optimized on, because as an interventional cardiologist, before I do a mitral clip, before we decide on CRTD methadone for patients with MR and we're trying to reduce their degree of mitral regurg, we say all of this comes after guideline-directed medical therapy, once you've optimized guideline-directed medical therapy. Now, where I find difficulty is in two areas. a lot of the trials, like the COAPT, etc., don't really give you a definition of the time of guideline-directed medical therapy. So in 1 month, does my patient qualify now for a device? In 3 months? In 6 months? Right? Especially that, as you all mentioned earlier today, every patient is different and they're tailored. So some you'll optimize quickly, some you won't. The other difficulty that I have is not only that the evidence doesn't really give you the direction in terms of time, but also when you look at what I'm aiming for and I'm shooting for. In heart failure, optimization means I keep pushing and pushing and pushing as long as my patient is tolerating and ambulating and independent. So defining optimization is very difficult. My target is a moving target in heart failure. So at what point would you, as a heart failure expert, give me the green light to put in a clip, for example?
Good question. I mean, it's a real life scenario. Maybe it's for the benefit, we don't have a clear, as you mentioned, a clear study that looks at these and studies the times and time difference and so on. But again, we go back to the patients. So if the patient showing any improvement when they are up titrating on the medication, we tend to give them more time. What's the hurry? They're improving, months, weeks, whatever. But if the patient is showing that, BNP is not improving, symptoms are not really responding, and if I may, they use the term of Dr. Musad, the patient is not kicking off. So, you keep him on this close monitoring, because most of them, they would require an intervention more quickly. But as we always call for personalized medicine and personalized healthcare, it's for the best. But the challenge is, do you have the platform or the logistics to follow all your patients like that? Do you have the manpower? Do you have the OPDs, appointments? Do you have the access? Now, this is a very strong question. What do you think, guys?
So this is a very common scenario that we usually get a lot. So a lot of patients gets referred for mitral clip, actually. And I think here where the heart team role comes in, and where if you have clinical pathways that can address this problem. What we've seen is actually a lot of patients, when they get referred for clips, most of them are actually not optimized. And if you optimize their guideline-directed medical therapy, their MR will go from severe to mild, okay? So this is where I think, although like the trial, if you look at the trial, COAPT to mitral FR, what they say is after optimization, and they don't define clearly what optimization is. So what I think that here where the clinical pathways or your hospital clinical pathway should kick in. So basically what we recommend is usually probably they get seen by a heart failure specialist, and you try and see if there's anything you can do from an optimization point of view. And usually you will have a rough idea. You hope that you finish everything within 2 to 3 months, and then discuss with your interventional colleague after repeating, this is what I'm doing for this patient, and if he doesn't improve or she doesn't improve, we're going to send them for a clip. But unfortunately, don't have clear timing. But I think probably what most people will agree with is within 2 to 3 months after finishing your optimization, if the patient does not improve, then you can consider going for a clip. But I don't think we have clear guidance on what to do with that. But clinical pathways and the heart teams is probably the best way to.
Yeah, I agree with you totally. And then we have worsening of heart failure. If the patient frequent visit to the clinic, or readjustment of his diuretic dose, or changing his diuretic dose, or just a frequent visit to ER without readmission or rehospitalization, those are the people or patients who have worsening heart failure, and they underwent the worsening heart failure criteria. So the basic, we just start all our medications, and if there is no response within 3 months, we will shift to a higher. This is in the algorithm of managed heart failure. So usually we give them around 3 months on maximum tolerated therapy, and we look at them. A stable patient, we know there is stabilized heart failure patients. However, symptom-wise, quality of life questionnaires, which is done very frequent, and dose adjustment for a few months is good. And then we reassess before going for any intervention, like the MR might be regressed from severe to mild, and to see that. But usually what the guidelines says is around 3 months. And post MI about 40 days. You remember a patient who had about 40 days, you will just go for any ICD or something, or instrumental intervention.
So as we come to a close to this program, I want to thank you all. And maybe I'll turn to the faculty now if you have any closing comments or takeaway messages to our audience, please.
From my part, thank you very much, Mr. Chairman, dear colleagues, for this opportunity. And we'll keep practicing and we'll keep praying for the better, inshallah. وإن شاء الله ربنا يبلغنا رمضان كل عام وأنتم بخير.
شكرا جزيلا ويعني thank you all and it's very nice team. تفضل دكتور مساعد.
لا تفضل. شكرا دكتور. Thank you everybody. Thank you Dr. Mirvet, Dr. Faiz, Dr. Kamal, to the organizers and everybody. Hopefully that was helpful. وكل عام وأنتم بخير مرة ثانية.
كل سنة طيبين. كل سنة طيبين.
كل عام وأنتم بخير. Thank you to Saudi Heart Association. Thank you to Boehringer for organizing this. I most certainly learned a lot. And I truly hope the Heart Failure Society, under the leadership of Dr. Kamal, reaches out to other members of the community. I think everybody's just as eager as I am to learn about what's new in heart failure and how to deal with it. A lot of us are very reluctant and kind of tiptoeing around the 4 pillars and how to start and how to negotiate it. And the more awareness there is, I think the more confidence there will be with clinicians to treat their patients appropriately. Again, thank you, and Jum'ah Mubarakah wa Ramadan Mubarak alaykum jami'an, inshallah. Assalamu alaikum.